overactive bladder in primary care for our community continence nurse team and pelvic floor health specialist around the Black Country. Ananda this afternoon will be going through the presentation around why it's important getting it right the first time in terms of managing OAB and potentially working collaboratively together as well to ensure patients' care is kept closer to home and only referred where necessary as well. Ananda is more than happy to take questions as we go along. If you've got a question while he's going through the presentation, please raise your hand or come off mute. But what would be even lovely is if you all did show your faces on the camera as well, so it makes it a little bit more interactive rather than just seeing initials, if you're happy to do that. Okay, I'll hand over to Ananda.
Thank you, Reena. Good afternoon, everyone. Nice to see you. So many people interested to know the update on the overactive bladder treatment. And as most of you may already aware of, Get It Right First Time is a national initiative. The main aim is to remove any discrepancies in the practice between various trusts and various departments. As Reena said, I am Ananda Dhanashekaran. I am a urology consultant from Sandwell and West Birmingham Trust. Many of you may have seen some clinic letters from me. And before I start, big thanks for all of you, because continence team and the nursing team supporting the patient is very vital backbone for the whole NHS patient treatment. So a big thanks for that. Today I'm going to go through few things. Before that, these are all my disclosures. Why get it right first time? It's important sometimes to get things right first time, not just in the overactive bladder treatment, even in our day-to-day life, family decisions, etc. And it really makes a big impact in a patient's life. If the doctor is able to select the correct dose and correct medicine to start with, that not only treats the symptoms quite early, it also gives them a lot of confidence and prevents them from exposure to unnecessary side effects. The practice is now very much improved, and we are using this Get It Right First Time in various fields like oncology, gynecology, prostate, and various other things. Now, what is the impact of overactive bladder in our normal patients? It really causes few important things like disturbed sleep, difficulty in taking part in social life. It disturbs work. Say, for example, if somebody is a surgeon and needs to do a surgery for 2 hours, 2.5 hours at a stretch, it's quite difficult if they have the frequency of urination. It disturbs the family life, it spoils the relationship, and it's quite bad with the mental health also. And it creates a good amount of anxiety among the patients. And in a survey of on an average of 3.5 years, elapsed before a patient appropriately started on OAB treatment. There may be a delay from the patient side, there may be a delay from the physician side in diagnosing it, and also there may be a delay in starting the appropriate medications. NHS is under pressure. This is something we have seen for many decades now. It's not something new. But when you see the number of patients waiting for outpatients, number of patients who are not able to get the appropriate slot, it's quite high. Just before the meeting, Reena was sharing with me some latest waiting periods. It seems that the number of weeks the patient needs to wait, especially in the Black Country, ranges from 35 to 42 weeks. Just think if one of us or one of our family member needs to suffer for almost 40 weeks without any proper guidance. That's where the management of OAB before the patient getting into the tertiary center, at the level of the general practice itself, like for example medications either by GP or the care of by the continence nurses like your team. Now, if you see into the NICE guidelines, the last one was updated with some good stress on the behavioral treatment. The importance of behavioral treatment we all know. If there is a big red flag like for example smoking or overweight or abnormal increase in case of the caffeine intake, obviously it's going to affect the patient's symptoms. and it's no-brainer to start these patients on medicines without addressing the lifestyle changes. The other main advantage is these behavioral therapies not only results in improvement of the bladder health, it will also give them a kind of overall well-being, a kind of good amount of weight reduction. They will have a good sleep. It also helps in treating the other diseases like hypertension, cholesterol, or diabetes, something which is happening in the background. And choosing the medicine, the main impact is number one, what the patient actually needs. Number two is the economics. We will discuss the economics of the medicines in one of the slide. And number three is how far the patient can tolerate that particular tablet. There is a good stress on early starting of sulfenacin as far as the anticholinergics is concerned, and also to change to mirabegron if the anticholinergics were not working. There are a lot of studies to support why mirabegron can be given a little bit upfront, and also why there is a need to consider even a combination treatment if there is a need. Many trusts around the world have got a clear guidance on managing the overactive bladder locally, like local trust guidelines. If you see this one from Doncaster and Bassetla, actually they are trying the initial diagnosis of ruling out the infection, making sure patient has no significant lifestyle problems, etc. And if there is no improvement, the first step is suitable anticholinergics. And they are quite happy to start with generic sulfenacin, which is relatively cost effective now because of being generic. And if there is no improvement, patient needs to be considered with mirabegron straight away. This gives them a kind of an upper edge and confidence in life. Many women patients especially have loss of work or loss of working days, loss of earnings because of delayed diagnosis and delayed starting of the medications. The best practice is changed, where previously the patients used to be kept on relatively less effective and high side effect profile anticholinergics for months and months, if not years and years, before trialing sulfenacin. The advantage of sulfenacin is not only its excellent side effect profile, as I said, because of it being generic now, cost effectiveness is also adding the importance to that. The pad usage is good improvement with antimuscarinic usage. Most of you know how the antimuscarinic drugs uses. We will discuss it along with the mechanism, antimuscarinic and mirabegron. You will be seeing this slide, get it right first time, few times in this presentation. So the aim is to start with one antimuscarinic, go with the best medicine which gives the quick improvement with less side effect profile. So ideal choice is sulfenacin. There is nothing wrong in trialing 5 milligrams and then changing to 10 milligrams if needed, because there is a good group of patients may be happy with 5 milligram itself. Obviously, if there is a less dosage, there will be less side effects and there will be less anticholinergic overload for the patient. And use mirabegron as a second line one. Yes, Reena?
Hi, yeah, just sorry. If we could just go back one slide before we move on. So the pad, just regarding the pad usage there. So the pad usage, if a patient started an antimuscarinic, their pads, with the first antimuscarinic, the pad usage may have been 55%.
Yeah.
But by cycling through an antimuscarinic, you're seeing that the pad usage actually increases, which you would expect to decrease after the second antimuscarinic. So what we want to do is keep that low, avoid it increasing. So what that one is basically showing is from that data set is that control studies, there's minimal benefits in cycling through an antimuscarinic. Exactly what you said there around sulfenacin, cost effective, the newer generation antimuscarinic. So with the pathway with Doncaster, that's what happens. But then what you are then doing is avoiding potentially pad increase by using another antimuscarinic. So that is what we want to avoid and break the cycle off. Sorry, I just thought I'd highlight that bit. Thank you.
Yeah, that's good. So the main improvement is the first antimuscarinic selected could be a very non-specific antimuscarinic, and also maybe because of the cost reasons. There is nothing wrong in trialing it, but if the patient is not improving, as mentioned by Reena and also here in this article, if the pad use is increasing, we need to change the antimuscarinic appropriately quite quickly. And it is better if primary care itself, either with the help of the continence nurse or the GP, trial the antimuscarinic like sulfasalazine and also change to mirabegron and refer to tertiary care only if these two are unsuccessful. It's very inefficient cost-wise if the patient needs to be referred by a secondary care physician like myself, and all I have to say is the lifestyle modifications and starting a sulfasalazine, which can be very well done closer to the patient by the GP itself. Not only it's economical, it also gives the GP a little bit more power in understanding the basic symptoms rather than just referring the patient directly to the tertiary center. So as far as the secondary care is concerned, if it is utilized a bit later when the sulfasalazine and mirabegron were not useful, that really creates a lot of space for the needed patients to be treated. How will you select an antimuscarinic? One of the important thing is the cost of acquisition. And sulfasalazine is a very economic one. I'm going to discuss the economics in a different slide. But at the same time, we need to make sure that the tablet is well tolerated, and sulfasalazine ticks that box also. Do not offer oxybutynin, especially the immediate release, because the immediate release requires multiple dosage and compliance will be very low, and it's better to have once daily dosage like how sulfasalazine and mirabegron were working. So be good in selecting the first choice antimuscarinic, and generic sulfasalazine is quite cost effective. The other reason is the selectivity. As we all know, the M receptors are of M1, 2, 3, 4, 5. There are 5 types of receptors. The M1 receptors were quite abundant in the central nervous system. That's why if a medicine is not selective, it can cause significant side effects of dementia and anticholinergic overload. If you see in this picture, the best predominant M3 selective is sulfasalazine apart from darifenazine, and ability to cross the blood-brain barrier is only moderate with sulfasalazine. Hence, we were able to prevent so much of side effects by taking sulfasalazine as a first choice of anticholinergic. And then if you look into the CNS adverse effects, the adverse effects itself is quite low, like dizziness and depression alone, and the percentage is quite low compared to the normal other cheap alternatives like, for example, oxybutynin. If you see the anticholinergic burden, sometimes the patients may be already having some problems like, for example, dementia, Parkinson's, Alzheimer's disease, and they may be taking some other medicines which accumulate along with the anticholinergics to create an unprecedented, quite high anticholinergic burden. It's very important to recognize this not on a later stage when the patient presents with worsening CNS conditions. Better to diagnose it early so that we can try avoid those drugs and have a good selective antimuscarinics. Now, the adverse effects like dry mouth, for example, is relatively quite good with sulfasalazine, and if you compare with 5 mg, there is a good 95% credible interval for the medicines, and the dosage is also once daily, so that gives you a very good compliance with the patient. If you see the adverse effects like dry mouth and discontinuation due to dry mouth when you compare to oxybutynin, the oxybutynin in the brown color is quite outperforming or bad performing compared to the sulfasalazine, and the discontinuation rate also is quite low with sulfasalazine. How far the patients are able to continue or persistent with the antimuscarinics? As you can see, sulfasalazine is the one which was continued to the maximum apart from fesoferidine, and oxybutynin is discontinued quite early. By making the patient to suffer with multiple low performing anticholinergics, we are only delaying the treatment and also making the patient to feel so bad with the side effects. Not only this, the window of opportunity of treatment, if it is lost and delayed, every day the bladder is getting irreversibly damaged. So those patients who had the sulfasalazine taken quite late in their disease progression may need to go for the surgical interventions, like, for example, like a bladder augmentation or sacral nerve immunomodulation or tibial nerve therapy. All the interventional treatments may be required at a later date. And you can see right from 2019 to 2023 and later, the sulfasenacin prescriptions have gone very high, especially after availability of the generic sulfasenacin. And this one clearly says the tariff. You can see that other than oxybutynin, sulfasenacin is one of the cost-effective drug with the cost per day in 4 to 5 pence, which is quite low compared to other medicines available for other diseases. So there is no doubt that sulfasenacin can be started as a first step or first choice drug at the level of the primary care itself. And the role of the continence nurses or benign nurses comes into play when they come across a patient. Many of you may have already done a prescription training, so your GP or your institute could be happy to support you in prescribing sulfasenacin also. Now, get it right first time. This is the motto of the today's talk, and as I said, the first one is starting correct, appropriate, less side effect profile, economic drug sulfasenacin, and using mirabegron as a second line quickly if the anticholinergic is not working. If one anticholinergic is not working, there is no assurance that the second line or third line is going to work. It's only delaying the treatment and delaying the making the patient to come back to their normalcy. So why mirabegron can work when sulfasenacin may have failed? Because both work exactly in an opposite type of mechanism. The sulfasenacin works via the antimuscarinic pathway where it blocks the M3 receptor. Because of this, it inhibits the contractions, while mirabegron works by sympathetic pathway while it activates the beta 3 receptor, and so it increases the relaxation. So there is a drug which improves the relaxation and there is a drug which inhibits the contraction. Because of this extreme different pathway, you may have seen sometimes the patients are not improving well with anticholinergics, and when they have changed to mirabegron, they improve suddenly with a very good improvement. And also the mirabegron, because of its entirely different pathway, there is no problems like, for example, blood-brain barrier crossing, dry mouth, dry skin, problems with cognition, etc. And also, as I said, there is also a small role of combining sulfasenacin 5 milligrams with mirabegron 50 milligrams, which I will touch upon a bit later also. So mirabegron is very effective. From the Scorpio study, we can see that incontinence episodes and the micturition frequency both improved quite significantly. Urgency episode is also improved with a p-value of 0.05, and nocturia episodes is also quite low when compared to placebo. Since there is a different side effect profile, you can see that if you see that mirabegron usage, the side effect profile in this dark color is much lower even compared to any antimuscarinics or the placebo, except for hypertension. So the hypertension happens because the same sympathetic agonist will result in increase in vascular contractility, which is the reason the hypertension can happen as a side effect. Is it important? Yes. But having said that, if you see the contraindications, it's only for quite high uncontrolled hypertensive patients, and there is no need to worry if the patient is already on stable blood pressure, on stable medications. And definitely mirabegron is not a problem with the patients who never had any blood pressure problems. Tolerability, definitely mirabegron is much more tolerable compared to sulfasenacin or any other drugs, and we can see that there are some minor side effects like, for example, UTI or headache, dizziness, tachycardia, but all the side effects were quite tolerable. In our day-to-day practice, mirabegron is one of the very commonly prescribed medicine, and I may have find very small group of patients not responding to mirabegron, but it's quite rare to see that the patient is suffering by side effects, requesting a change of medicine or stopping of the medicine. And how many patients who are taking the medicine, keeping it for long term? If you start 100 patients with these drugs, we can see that mirabegron is quite outperforming compared to any of the anticholinergics. Mirabegron dosing should be adjusted for patients with liver or kidney failure, and maybe instead of 50 milligram we can go for half a dose, which is like a 25 milligram. And some patients who are on CYP3A inhibitors, like for example antiviral drugs, we need to be careful because those CYP3A inhibitors will stop the mirabegron metabolism. So the accumulation of the mirabegron in the blood will be higher. So even if you give say 25 milligrams, it works almost equivalent to 50 milligrams. So there is a separate dose for with inhibitor and without inhibitor. If the patient is on with inhibitor, stick with 25 milligrams, and also for those with renal or liver problems. It's contraindicated in pregnancy because there's not much studies done. We need to be quite careful in giving any tablet with pregnancy, including paracetamol, I will say. And as we discussed already, severe uncontrolled blood pressure with systolic blood pressure more than 180 or diastolic more than 110, it's better to defer the mirabegron. As we all know, nobody will be happy with this high blood pressure. Obviously, this patient needs much more quite good titration of the antihypertensives, and within a week or two the blood pressure will get stable and patient may be suitable to start the mirabegron. There is no real strong special warnings other than what I mentioned about the renal and hepatic impairment, and the patient already on hypertension can be started safely as long as it is monitored at correct interval. And if the patient had any congenital or acquired QT prolongation, which can be seen in the ECG, again it's a relative contraindication. And bladder outlet obstruction, even though it is mentioned that antimuscarinics or mirabegron can cause bladder outlet obstruction, especially in men with prostate, I quite rarely come across this problem. Yet today I've never seen a patient because of mirabegron or sulfenazine going for urinary retention. Yes, once in a while patient may say that, doctor, my frequency is good. I'm not getting up as frequently in the night as before. I don't have that urgency, and also the minor urgency leak, urge incontinence is also better. But the urine flow is a touch slow. That may be one of the concepts. If you explain the patient how it works, how the mirabegron results in relaxation of the bladder, they will understand, okay, since the bladder is relaxed, that's how the symptoms got improved. So since a relaxed bladder, it won't give the force what they need to be. But it should not result in retention. And say men with BPH, they will be helped with tablets like tamsulosin or finasteride, and women rarely have the problem of slowness in passing urine or retention. So as I said, this is a slide we are going to see again and again. So just to stress again, start with the correct antimuscarinic, which is having less side profile, better tolerability, and also very economical, which is sulfenazine. And if it's not working, maybe in 6 weeks time, feel free to change to mirabegron, which is the second line. Of course, if the second line tablet is not working, we are here to help and the patient needs a tertiary care referral. Thank you for patient listening. In summary, overactive bladder is a big disease burden. Unfortunately, the need for the treatment at the level of the primary care, at the level of the continence nurse, at the level of the GP is quite high. Even today, we can see so many patients were referred to us without even properly discussing the lifestyle changes. I'm not saying this as a criticism. Unfortunately, we know that the GPs have very less time period for them to discuss. The easiest thing is get hold of Reena. She's got some information leaflets on lifestyle changes. Just hand over the leaflets to the patient so that they will try to use all the changes, like for example, weight reduction, avoiding constipation, changing to decaffeinated drinks, avoiding smoking, etc. And that will really make them good, strong in their personality. And if there is a need, start with anticholinergic like sulfenazine and change to mirabegron if needed. Of course, if the tablets are not working or if there is a compliance problem, we are here to help. If this kind of primary care oriented treatment is happening in every possible diseases, we should be able to treat most of the patients closer to their home in a very economic manner, and the secondary care can be reserved for the complex patients, and it will really ease off the pressure in the system. I hope it makes sense. And this is a QR code for the mirabegron and Visicare prescribing information. Feel free to scan them, and also feel free to give a feedback by the QR code in the chat box. Happy for any questions.
Do you want to stop sharing your screen, Ananda? Yeah, I think there are some questions that have come through. I've got hands raised as well, so just have a look at them. Liz, would you like?
Yeah, I've got two questions, thank you. The first one is, how long would you prescribe solifenacin for before changing it?
Yeah, as per the NICE guidelines, it's 6 weeks. If you see the NICE guidelines, so there are three things. The first thing is, if it is us, if it is our relative, do you think if medicine is not working, we will just ask them to take it for 6 weeks? That is the first question. The answer is no, but the problem is the accessibility back to the GP or back to yourself. So we can give lot of information, like for example, if I see a patient, what I tend to do is, because my clinics, I can't see the patient for the next 3 months actually. So I will instruct the lifestyle changes in detail, hand over the leaflets to them, and ask the GP to start on solifenacin 5 milligram. If it's not working, 10 milligram, and feel free to change to mirabegron 50 milligram. My letter will be quite comprehensive so that within 3 months the GP can play around and change to mirabegron. If you take NICE guidelines, it is 6 weeks. But it's better to be a little bit flexible to the patient. Maybe most of you may be happy for the patient to ring you. So if the tablet is absolutely not working for 2 to 3 weeks, or if it causes dreaded dry mouth or constipation, nothing wrong in changing the tablet in the 2 to 3 weeks itself.
I've got a second question as well, if that's okay. You said that you don't find many patients experience retention with anticholinergics. However, we actually do find quite a lot of people with high residual volumes taking anticholinergics. What would you consider to be an acceptable residual volume, post-void residual volume, in an elderly person taking anticholinergics?
Yeah. So residual volume is not something sweet to have, because the problem is it not only gives them a kind of a very uncomfortable feeling of not emptying the bladder fully. The residual urine is just like a drainage which is not draining well. It becomes a nidus for the infection, and it can cause secondary problems like stones, and patient may end up in a proper urinary retention on a later date. The easiest thing is, if you have a document of the residual urine before starting the medicine, that will be quite handy. Unfortunately, a lot of times we may not have a residual urine measured before the medication. If before the medication, sometimes patients may be having a residual urine of 200, 210 living around comfortably. Yeah. After starting the medicine, they may still have the same residual urine, so it doesn't matter at all. The easiest thing is, for a woman, any residual urine up to 100 ml is fine. For a man, almost the same value. But the only thing is, if the residual urine crosses 100 ml, ask the patient to perform double voiding, which means we need to tell them, when you are peeing, you are not emptying the bladder fully. There is a 150 ml, 200 ml in the bladder. So once you come back to your sofa, after 10-15 minutes, nothing wrong in going and emptying again. Double voiding, if repeatedly done, what's happening is, the first time, say 500 ml becomes 200 ml, and the second time that bladder tries to empty the 200 ml also, it will never become zero. They'll be always having some 20 ml, 50 ml, which is fine, which is quite physiological. That second voiding trains the bladder to empty fully. Once you start doing this double voiding periodically, at least few times in a day, at one point the bladder will know that we need to empty completely, otherwise this person is going to empty or try to empty in another 10 minutes time. So double voiding is a good technique to start if the patient is asymptomatic. Of course, if the patient is symptomatic due to the residual urine and few other things, we need to take it in a different way. Intermittent catheterization is a good way, where if the patient, if they know how to catheter themselves, if there is excessive double voiding, they can just catheter maybe just twice a day, once in the morning, once in the night. That will take care of the double voiding.
Okay.
Thank you. Emmy, you had your hand up. I've noticed you popped it back down again.
Yes, thank you very much, Doctor, for your presentation. It was very helpful. Actually, Liz, you've actually asked one of the questions that I had, because we do tend to have a lot of people that come into clinic, especially on solifenacin, on the lowest dose, 5 milligram, and we tend to do bladder scans every 3 months for them. And I do find that we do get quite a lot, quite a high residual post-void, and typically patients will say, well, I don't feel like anything is in my bladder even after they do double void.
Yep.
So in which case then, and we're talking about post-void residuals of 200 plus, and in which case then, I tend to just omit to request the GP to omit if they can, because of the risks involved in such as infection and things like that. So I did wonder what was the threshold in terms of what can we allow, but you have said 100 mils.
Yeah.
But unfortunately we do tend to find 100 mils plus, and then in which case it's kind of very difficult then to know where to go from there.
Yep.
Because patients will say that they have noted significant improvements in their symptoms, but then now when they are not completely emptying their bladder, it's also another thing to worry about.
Yep.
So
Yep.
yeah.
So the steps are, as you said, the first thing is symptoms, because let's first make the patient to feel better. You're correctly doing by making the symptoms are getting better. Regarding the residual urine, as I said, double voiding is a good technique. The next one is, if the patient is on solifenacin 10 milligram, we can go to 5 milligram. Sometimes with that improvement, even with 5 milligram, they will have the same improvement, but the post-void residue may reduce. The other thing is considering mirabegron, as we just discussed, both work in a different pathway. So maybe in one pathway the bladder retention is slightly higher compared to the other pathway. If the patient is on combination of solifenacin 5 milligram and mirabegron, we can stop the solifenacin and continue only mirabegron. And we need to make sure the fluid advice. So especially this is a problem in men compared to women, especially with the retention, increased post-void residue, etc. Women sometimes will never end up in retention. They will be able to pass urine well. And if it's a man, if they are interested in having a couple of pints of beer, they need to be very careful, because any episode of increased fluid intake, especially the diuretic drinks like beer or excessive coffee, can result in precipitative retention, which may make them to come to A&E for an emergency catheter, etc. And if we know that this patient has got an increased residual urine, there is nothing wrong. If the patient is happy, we can teach intermittent self-catheterization. It just needs to be done only twice a day minimum, once in the morning, once in the night. What happens? Once in the morning, once in the night, because of the self-catheterization, if the bladder completely empties, then in the next void, it will accumulate a post-void of 50 ml. In the next void, it will become a post-void of 80 ml. So the post-void will slowly increase, and by the time evening, if they do one self-catheterization, again it becomes zero. So we are trying not the post-void to just accumulate without our control. Ideally, if the patient has got very significant post-void and also severe difficulty in passing urine, the catheterization should be done something like 4 to 5 times or 6 times a day. But if the patient is passing urine well, they don't feel full, they are quite happy with the tablet, there is no symptoms at all, but the residual urine is the only problem, just self-catheterization twice a day is a good way to keep the bladder empty.
Thank you. Are there any other questions from anyone else? So, Amanda, you've had there we go. We've got 2 in one go. You got the first, Liz.
Sorry, I just wanted to clarify with what you've just said about the if they're asymptomatic but they've got a high residual, would you teach self-catheterization and keep them on the medication, or would you stop medication?
No, we can keep the medications, because medication is the only thing keep them asymptomatic. So keep the medication and self-catheterization only if it's more than 200 ml. Less than 100 ml is normal. 100 to 200, we can just educate the patient to be a bit watchful, like double voiding. More than 200 ml, it's better to teach self-catheterization.
Yeah. Okay, thank you.
All right, and Steph.
Hi, I just wanted to, you mentioned using this combination therapy of solifenacin and mirabegron. Are there particular patients that do well with the combination, and are GPs happy to double up on the medication as well?
Yeah, this combination of solifenacin 5 milligram and mirabegron 50 milligram is well studied. There are many publications in it. Reena may be happy to give you. If not, I'm happy to give it to Reena so that she can pass it on. The main advantage is, as we discussed, both work in a different pathway, and so both work complementary. And the side effects are completely different. There is no additive side effects, and the price also is quite okay. We are not giving 10 milligram solifenacin because the studies happened like that. It's 5 milligram and 50 milligram mirabegron. And also by giving only 5 milligram solifenacin and 50 milligram mirabegron, we are avoiding unnecessary increased post-void residue or retention. I've done few times prescribed that. There are also some pharmacy companies gives a combined treatment also in one tablet, a slightly different dose, something like solifenacin 4 milligrams and mirabegron 50 milligrams. There is also combination available for solifenacin and tamsulosin for men. So the combination treatment is definitely useful, and because if you're starting a tablet, patient said, I'm okay with that, and then after 6 months, 4 months, they fail on solifenacin, say for example. And then you start on mirabegron, patients are happy, again in 2 years time, they find, doctor, individually both tablets are okay, but when I take it separately, I'm not getting that fulfillment. So if you combine, they will feel that may be a good titration for them. End of the day, it is not just empowering the patients, it's also empowering the GP that there are more options for them before jumping into the tertiary care. Because once the GP elapses all the options of solifenacin, mirabegron combination, and then when the patient lands on us, then we can directly go for sacral nerve tubulation, posterior tibial nerve tubulation, some interventional treatment, which will be very cost-effective pathway.
I had a patient only about 2 weeks ago who with a medication error was accidentally on both solifenacin and mirabegron, and they found their symptoms were great, and then they rectified the prescription, and I think she was just left on mirabegron. And she said if I could have both, I would, my symptoms would be so much better. So I thought I'll ask that at this talk, and you covered it already, so yeah. I've got the answer. Thanks ever so much.
Yeah, with solifenacin being generic and also mirabegron going to be generic in say 1 or 2 years time, combination is also a very economical mode.
Thank you.
And just a caveat from me, obviously mirabegron is licensed monotherapy, but we know clinicians like yourselves do use a combination, so we're not promoting it. That is the opinion of Mr. Dhanasekaran's clinical expertise. Yeah. Just my little quote there, sorry. Might get applause. But yeah, any other questions at all? We've got the clinical expert here, and we've got nurses from Dudley, we've got them from Sandwell, West Birmingham, Walsall, so this is your time to make the most of any other questions that you may have around urology. Yeah. Fantastic. Well, I hope you've all found the meeting useful. And it would be great. Only 7 people have signed in to the registration. When you finish the chat, when you log off, you will no longer have access to the chat. So I did take a picture of the QR code, so you've got it. Please do sign in. It just means that I can then get your certificates out to you. I've got all your email addresses anyway.